بسم الله الرحمن الرحيم الحمد لله وحده والصلاة والسلام على من لا نبي بعده. السلام عليكم ورحمة الله وبركاته. I am Dr. Zakaria Gannoun, consultant in diagnostic radiology, and we will talk a little bit about cardiac CT and updates today. So in the early days, cardiac CT answered exactly one question. Is there a flow-limiting stenosis? Yes or no? Today, from a single exam, it can read the lumen, it reads the muscle, it reads the pressure gradient across a lesion, it reads the wall and the biology inside it, and it can even draw the surgeon a map of the operating field. 5 jobs, 5 answers, 1 scan. Let me start with its superpower. The superpower of the cardiac CT is the reason why guidelines worldwide moved CT to the front line for chest pain. The strength of coronary angiography, of coronary CT angiography, is its negative predictive value. It means that a clean CTA in a patient with stable chest pain effectively excludes significant coronary disease and sends that patient home instead of to the catheter lab. That single fact spares an enormous number of people an invasive procedure they never needed in the first place. And it is why a normal CTA is one of the most reassuring sentences in cardiology. We can even get value before the contrast goes in. It's the non-contrast calcium score, which is a fast, cheap, low-dose readout of total atherosclerotic burden. Remember what calcium actually is, though. It is the scar of the lesion. It is the scar of a stabilized plaque, not the pathology in itself. So a high score, of course, is a loud alarm, and a score of 0 can be reassuring in the asymptomatic patient, but never let a 0 talk you out of a CTA in a young symptomatic patient, because the plaque that kills the 40-year-old is a soft, non-calcified plaque and devoid of calcium in the majority of cases. Remember, none of this works if the images are blurred. So let me give you the one thing that matters during the exam, which is heart rate. Heart rate is king. A slow, steady, regular rate in the 60s, and I stress it, regular, because every gating algorithm in the CT scan, because CT scan will use algorithms to reconstruct the images, these algorithms will gamble that the next beat looks like the last one. So irregularity will give a hard time to the CT reconstruction. We get there using beta blockers and a hit of sublingual nitroglycerin to dilate the coronaries so the CT lumen looks like what the angiographer would see. Then comes the one primary decision: how to sync the X-rays to the heartbeat. We have 2 solutions: prospective triggering, which fires the tube only during a narrow, quiet window. So the prospective triggering will have a low dose, but it is rigid. You cannot change it in post-processing. It is your default for the calm, regular patient. The second solution is the retrospective gating, which leaves the tube on across the whole cycle of the heart, meaning higher dose, but it lets you reconstruct any phase, measure function, so it is your friend in arrhythmia. So we have our beautiful images. Now we need a common language, and that language is CADRATS. Think of it as a sentence with 3 parts. The backbone is, of course, the stenosis grade, taken from your single worst narrowing. 0 is clean, 1 is minimal, 2 mild, 3 moderate. That is the flow-limiting threshold where physiology testing earns its keep. 4 is severe and splits into 4A and the scary 4B of left main or 3-vessel disease. and 5 is occluded. On top of that, you add the plaque burden score, P1 to P4. And this addition matters because burden predicts risk independently of any single stenosis. You can be Cadrat's 1, but P4. One mild narrowing, but plaque smeared through the whole tree. And that patient needs aggressive prevention, not reassurance. Finally come the modifier letters, S for stent, G for graft, HRP for high-risk plaque, and the newest one, I for ischemia, which you add when you have done physiology testing. So a report that reads 4A, P3, I positive tells the referrer in one compact sentence, severe stenosis, heavy burden, proven downstream ischemia, anatomy, burden, and physiology in a single line. That is the entire point of the system, which brings us to the most important idea in this whole field. The stenosis you can see is not always the stenosis that matters. A tight-looking lesion can be physiologically silent, and a modest-looking lesion feeding a huge territory of muscle can be the dangerous one. We have two tools to settle that argument. The first is CT perfusion, and its logic is almost childlike. It's very simple. Blood carries contrast, so wherever blood goes, brightness follows. At rest, stenosis hides because the little vessels downstream dilate to cover for it. So we cheat. We stress the heart with a vasodilator. Force every microvessel to open to maximum and watch. Healthy muscle floods with contrast and stays bright. Muscle starved by an upstream narrowing cannot keep up and goes relatively dark. Normal at rest, dark under stress. That is reversible ischemia, caught in the act. And perfusion will not add much radiation to the patient because during this exam we only cover the left ventricle. So against the nuclear scan it replaces, it is competitive or even better. The second tool is the one that still feels like science fiction. It's CT-FFR, fractional flow reserve, computed without a tube, without a wire, without a stress drag, without a second scan. So picture blood as water in a pipe. A real stenosis drops the pressure across it. And FFR is simply the ratio of pressure beyond the lesion to pressure before it, with 0.8 or below, meaning this one is worth opening. The trick is that software rebuilds your patient's coronary tree in 3 dimensions from the CTA you already have and simulates the flow. So it computes that pressure drop without ever touching the patient. Now, the worry everyone raises is calcium. They say, if there is much calcium in the coronary tree, you will have a failed CT-FFR exam. But recent studies that failed analysis failed because of motion, not calcium. So when a CT-FFR case gets rejected by your software, don't blame the calcium, go back and fix your heart rate. Used well, CT-FFR has carried CT across the line from triaging who goes to the cath lab to actually directing treatment. Now, analysis of the wall, where imaging meets pathology or histopathology, and where we have to correct a piece of information that misled a whole generation. We were all taught that most heart attacks come from mild lesions, and people heard that as infarcts are random, so why bother with the small stuff, with the small stenosis? It was wrong. Those lesions, which looked mild on the baseline angiogram, but the infarct came years later, after the plaque progressed. The real message is that mild, non-stenotic plaque is not an incidental finding to forget. it is the warning, because progression is the necessary step toward infarction for every plaque. So we read the wall, and every high-risk sign is a window into histology. Positive remodeling, which is the Glagov phenomenon, which is the artery bulging outward to hide lipid-rich plaque while the lumen still looks innocent. Those are your thin cap fibroatheromas, the ones that are prone to rupture. We have also the napkin ring sign, which is a low-density necrotic core wrapped in a brighter fibrous rim. We also have low attenuation plaques under about 30 Hounsfield units, which betrays a lipid core again. And finally, spotty calcifications marking active, angry, and stable disease, not the calm, healed lesion. 2 or more of those features, and you call it high-risk plaque and push prevention harder. And then, in its final act, cardiac CT leaves the coronaries entirely and walks into the operating room. Before minimally invasive valve surgery, usually the mitral, repaired if it is pliable, replaced if it is calcified or infected, the surgeon works through a tiny gap between the ribs with long instruments and the camera, essentially operating blind. You are their eyes before the first cut. You tell them which intercostal space sits at the dome of the left atrium. You measure the depth against the roughly 20 centimeter reach of the instruments, and you check the iliofemoral vessels for safe access. There is also another checkpoint to evaluate. In these operations, the bypass machine runs blood backward up the aorta to reach the brain. So the aorta must be clean, perfect. A single mobile plaque becomes a stroke, and you hunt for the anatomical traps that sabotage cardioplegia, a tight coronary that won't let the protective solution through, a left-sided superior vena cava that drains it away, an ASD that lets it decompress. Your structured map, rib spaces, skin markings, the aorta, the deal breakers stated before, can decide whether the patient gets a sternotomy or a 5 centimeter incision. So in conclusion, cardiac CT reads the lumen with angiography, the muscle with perfusion, the pressure gradient with CT-FFR, and the wall with plaque analysis. And then it draws the surgeon's map, anatomy, physiology, risk, and the operative plan, all from one non-invasive study. So with all of this, cardiac CT is not just a test that answers one question. It answers at least 5. Thank you. Next time, inshallah.